wonderful panelists, going through my most educational case in the COVID pandemic period. The date stamp for today is the 6th of March 2021, Saturday, 8 p.m. in Singapore and probably a.m. in the rest of the world. This session is co-endorsed by the Singapore Cardiac Society in proud collaboration with Abbott Vascular. My chairs for today will be Professor Eeckhout from Switzerland, as well as Dr. Ho Lam from Hong Kong. Our first speaker will be Dr. Carlo Di Mario from Italy. He's going to speak to us and share a case on when it rains, it pours. 3 vessel disease, severe functional MR catching a COVID-19 infection. Our next speaker will be Henry from Hong Kong, an 18-year-old patient with cardiogenic shock. Dr. Gupta from India, PCI, all the tools and limited options. Stijn Lochy from Belgium, when faced with not only a coronavirus on the loose, a challenging MitraClip case. David Ho from Hong Kong again, cardiogenic shock with and dilemma in antiplatelet therapy. Dr. Satoshi from Japan, COVID-19 pandemic is associated with mechanical complications in patients with ST elevation MI. Dr. John Yap from Singapore, a case of epic proportions. Our panelists today range from really a transcontinental panel. From Australia, we have Sydney Lowe. France, we have Thierry Lefebvre. Christoph Jensen from Germany. Anthony Wong from Hong Kong. Enso Jan from India. Dr. Liu Hongbang from Malaysia. Sergei Volkov from Russia. Malcolm Bell from the USA. Lucio Paliscia from Argentina. Satoshi Honda from Japan. The content is copyrighted by APSC and should not be distributed without the prior permission of APSC. The views and opinions expressed in this webinar are those of the faculty members and do not necessarily represent those of the APSC. This content is currently made available live by Wonder Medicine, the APSC Facebook and YouTube pages. For Singapore registered physicians, CME point will be submitted for attendees who are connected throughout the whole duration. You will receive your certificate of attendance upon completing a survey sent by email post-webinar. For attendees dialing in live, please type in your Q&A if you have any questions, and we'll try to answer all of them if possible. A pitch for upcoming webinars. Next week, we have a live workshop for fellows focused on the APSC bifurcation workshop on DK Crush. 18th of March, we have another session on protecting AF patients with diabetes beyond stroke prevention. So let's get started with Professor Di Mario's lecture. Before he starts, we'll have our opening remarks from our chairs, Professor Eeckhout, as well as Dr. Ho Lam. Eric, please.
So I'm very happy to be part of this Trans World webinar. I think it's exciting to see that we are all connected throughout different time zones, and we are going to share our most educational cases. I'm looking forward to it. We will have to handle the panelists because we are quite a lot of people, and we will have to manage time. So I will be guided by them by Lam Ho, who may say also a few words, and I think then we should start as soon as possible because we want to see what Carlo wants to share with us today.
Yes, I think the audience are waiting for the great cases. So maybe we can start and don't waste the time.
Okay,
yes.
Let's go ahead. Carlo, we are listening to you. The floor is yours.
Yes, I'm looking forward to the great case.
Going to the very beautiful city of Florence.
Thank you. Sorry, we are not seeing much of the city, but I hope to share with you an interesting case. And in fact, it's a very recent case of a COVID patient. And the moment of truth is always when these videos work. And I hope this is the case. And you see my slides now. So my most educational case in the COVID pandemic period. And well, I think you have seen many of these happenings, patients who may come to hospital for severe coronary or in general cardiac problems, and either they are brewing or they catch a COVID infection. Catching is, of course, the worst, with some possible medical legal consequences, but in this case, most likely was something that was already going on. And unfortunately, as you can see from the graphics of the pandemics in Italy, we believed that in March last year was the worst time, but the second wave was much bigger. Also, you see that symptomatic patient remains much less than infections. And the second wave never finished, unfortunately. And we are, especially in our region, in what we call a red area, with a very difficult time indeed. What we notice in this second wave is that also relatively young patients tend to catch the disease, as you can see. But of course, they tend to remain asymptomatic or very mildly symptomatic. Only elderly patients develop severe or critical illness and possibly tend to die of it. And unfortunately, the patient I'm talking about is one of them. 78 years old, female patient, classical cardiovascular risk factors, including kidney disease. She developed in the past paroxysmal atrial fibrillation and was placed on warfarin. Don't ask me exactly whether it is due to the fact that the level of renal impairment was such to be considered a contraindication to oral anticoagulants, because she was treated in a nearby city. She developed severe breathlessness and 3 weeks ago went to hospital to a nearby town. COVID was negative, COVID swab was negative, was admitted was admitted to hospital because of this, and was undergoing a coronary angiogram that showed left main trifurcation disease. At that point, the advice of the colleagues was for surgery, and since they had an overwhelming surge of COVID-19 cases in their hospital, they decided to at least get her closer to the surgical unit, which is only in our city hospital of Florence, and transfer her to an internal medicine unit. At that point, you always do a swab before transferring, and probably again brewing, because it was only 3 days in hospital. This was positive. So at that point, couldn't go to the place where it was supposed to go. I'll tell you what's the situation, because you go to a COVID unit, but you are speaking of a very severe sick patient, both on a cardiac and the general internal medicine view. Is a patient with complete left-bundle branch block, still sinus at that time, with normal red and white blood cells and no obvious signs of severe infection, with a troponin which is minimally raised, with this very high level of creatinine, with liver impairment is obviously the cause of the fact that the warfarin led to this absolutely out of control level of INR of 3.0, and with an extremely severe cardiac impairment with an NT-proBNP, which is greater than 10,000. Echocardiography shows 25% ejection fraction, diffuse hypokinesia. There is, besides annular calcification, also dilatation of the annulus, with moderate to severe mitral valve insufficiency. Degenerative aortic valve disease with moderate stenosis was expected to undergo likely a 2-valve intervention plus 3 vessel bypass graft operation. But now there is the COVID in between, and you look at this poor LV function, this severe central jet of functional severe mitral regurgitation. At that point, you have to consider overall what you can do for a patient who is not going to your cardiac HDU, but to the COVID HDU, certainly extremely capable anesthetist to deal with lung problems, maybe a little bit less with cardiac support. So should we wait that the infection is clear and then possibly proceed to surgical treatment? Very unlikely to operate somebody with active COVID, or should we go for something else? And the decision was, I think, prompt from what you will see in the next slide, which is this type of disease. Is a left EBU 3.5 catheter, 7 French. We normally go with a slender glass sheet and using the balloon, putting a balloon in front of the guiding catheter. I think I've succeeded to apply also these relatively large catheters in very small ladies, such as this one. When you go there, I don't like to have side holes. I think you waste the contrast and you don't have an optimal imaging of the ostium. I just have my wire ready. I push it in. After my first image, I had already the diagnostic, so I didn't need to do anything else. You see, looks, there is even poor flow down the left circumflex. Will be better after my wires. I push out with this wire that goes to a tiny branch of the diagonal, my guiding catheter, and then I keep going with multiple wires, and at the end you will see 4 wires, because I wired not only LAD, CIRC, and intermediate branch that in fact proved to be an early diagonal and not a true intermediate as was felt initially, but also the second diagonal branch, because over here, you have to trust me because I don't have the diagnostic angiogram. There is another severe lesion in the mid LAD. So this is what you have, is a classical bifurcation lesion with an open right coronary artery, dominant but not particularly prominent in terms of distal vasculature for the posterolateral wall. Very poor left ventricular function, severe mitral regurgitation, complex calcific, there is calcium here, left main disease. Should we go for left ventricular assistance with the impeller? I would say I would normally do for such a patient. In this case, there are 3 contraindications. Very small femoral vessel, and with that creatinine, we didn't do an angio CT to prove whether it was doable or not. We have, as you have seen, experience of using a peripheral shock wave to get through even small calcified iliofemoral vessel with impeller, but in this case, we didn't have any angio to know what the anatomy was. Is a patient who, despite the INR went down a bit, waiting those 3 days, already has a level of INR, which is almost on the therapeutic range. And of course, you have to add heparin is on board. She has a clopidogrel and aspirin. As a moderate aortic valve stenosis, that is always difficult to quantify in a patient with a very poor left ventricular function. So these all led us to decide to go for an intervention without protection. Of course, keeping catheters out of the way, keeping balloon inflation as short as possible, and not the ideal case to show in such an event, doing almost no angiography because we wanted to spare contrast. So besides what you will see, very little extra contrast was used. This was one of the injections we did after a generous kissing balloon dilatation, CIRC and LAD. I don't do much kissing before stenting in general, but in this case, I couldn't afford to have one of the 2 vessels crushing. You have seen how large the CIRC is. It's a dominant right, but with a very prominent CIRC as well. And good news is what you see here. There is good flow down all vessels that TME 1 flow that you saw in the circ is now replaced by a good TME 3 flow, and the balloon expanded. Maybe here there is still some residual indentation, but you definitely don't have the worst calcified, undilatable lesion in the world. At this point, we have the way open to stent the mid-LAD, and again, you will need to believe, trust me and trust this echo that shows immediately after stenting good matching with the distal vessel, a quite nice vessel, reasonable expansion, but still some extra work can be done. In the interest of time, I won't show the entire pullback, but I show you some images of the most interesting segment, which is the very proximal LAD and this very short left main. So calcium is present, but is eccentric calcium and less than 180 degree. We already have evidence from the balloon dilatation that balloons expand. So at this point, we decided to go for conventional treatment without using shockwave, which is in general our standard. Of course, with shockwave, you do have a little bit more ischemia. I had a very similar case the week before, done with Impella, was extraordinarily easy. You can take your time to adjust the position of the balloon. Is of course very short, 10 seconds inflation for the activation of the lithotripsy, and you can have some time between one inflation and the other, but still is some extra ischemia that if you can avoid, I think is better. So at this point is a classical DK crash. I noticed that next week you will teach us how this technique works, and is a technique in fact coming from China, and also is a modification of some original concept that Colombo introduced a long time ago at the end of, we are speaking of last century, 25 years ago. But this technique, I think, tends to work better. You crush, and mini for me means 1-2 millimeter maximum the stent. In this case, you also don't have much extra space because you see the aorta is there. This is my third contrast injection. I use very little injection. There is no side hole. You don't waste much. At this point, you expand your 4 millimeter short stent in the left main and left circumflex. Then you pull back the balloon and you crush the stent with an appropriately large balloon in the left main, leaving, of course, protection of this early diagonal branch, almost an intermediate. I could withdraw the fourth wire. I think 2 balloons and 4 wire in a 7 French may give some issues, but 3 wires and 2 balloons is, of course, a piece of cake. Then you have the implantation of the stent for the left main and the proximal LAD. I left a gap between the mid LAD stent and this stent because there was a relatively healthy segment confirmed from ultrasound. Of course, I had to move at this point from a spider view to a left cranial view where you can see very well the origin of the vessel from the left main and where I have to stop with my stent. But ultrasound also helped me in the selection of this 18 millimeter times 4.0 Zion stent. I participated in the trial that in a way opened the way to treatment of left main with the intervention using that stent. I tend to use it most of the times. Rewiring, I tend to use a Pilot 50. Was not particularly easy, not much the rewiring, but passing a new balloon. When you have a very short left main, you have really to find the way through, and I had to go with a 1-6 millimeter long single marker balloon to make a small opening and then go with the larger balloon. And this is my first kissing with the 4.0 and 4.0. At that point, I did ultrasound on the circ, and I noticed that there was some distal disruption. So I placed another short 8 mm stent more distal to the circ stent, and this passed with no problem. So my kissing worked very well at this point. I did a very gentle 2.5 mm dilatation to the early diagonal. My plan was not to stent unless I had TIMI2, TIMI3 flow or extremely severe lesion. And I did a final pot with a 4.0 at this level with most of the balloon protruding outside. And this is my final outcome that obviously I checked also with intravascular ultrasound. Numbers tells you maybe more than this a bit rugged appearance of the lumen. We are speaking of lumen above 2 square millimeter in the left main, of a 10.8, still quite eccentric lumen in the level of the bifurcation of the circ and diagonal, and the LAD is 7 square millimeter. I think I did accept this particular point, and this is my final slide. The lady, in fact, didn't catch a true disease. Was positive, but all the markers remained negative. There was no pneumonia, and her creatinine kept improving, as well as all the other values of her blood test. She could be switched from warfarin to a low dose new oral anticoagulant, and her left ventricular function improved in the 10 days she remained in hospital with an MR that was no more of surgical importance. In fact, we didn't even consider her for ICD biventricular pacing. And fortunately, in this case, COVID was not an issue. The reason why somehow we rushed the patient to the cath lab was also a specific request of our colleagues from the COVID unit. What they said, with that condition of pre-shock, if she catches even a mild pneumonia, that will be a death, a certain death. So treat it, do your best, palliative, but I think it's a palliative that is going hopefully to last long. Thank you.
Thank you very much, Carlo. That was very impressive. Yeah, I think the floor is open for discussion. Maybe I think it would be nice to stay in Europe. Thierry Lefebvre, I think that's a bifurcation. Can you switch on your microphone and maybe comment Carlo's case?
Thank you very much, Eric and Carlo, for this great case. I would have used intra-aortic balloon pump in this particular case. I don't know, we discuss about support of the patient, and I think intra-aortic balloon pump can be very useful in this kind of situation when you do kissing balloon inflation, or you have a long inflation for any reason. So it stabilizes the patient and gives you more time to do a good job. In terms of strategy for the bifurcation, I think I would not have used decay crush technique, but I think it's a good option in this particular case. I would have used a provisional with 2 or 3 stents at the end, and maybe a long stent for LAD left main in order to have something more simple instead of putting a stent in the LAD and then treating the left main. But I think your case is a good illustration of the problem of COVID. Probably this patient would have gone to surgery in Florence, but because of COVID, you had to deal with this kind of situation in a very complex patient. So, and you, at the end, you have a very nice result. So I think it's a very indicative case.
Yeah, I think that, Carlo, what do you think? Because there is some controversy about us doing these very complex left mains, and the literature still tends to, maybe also you can comment, Thierry, indicates, and all the trouble that was around the trials that were published on mortality in high risk, long-term mortality, of course, in this high risk left main PCIs that tend to do very well. What do you think about literature? How do we want to interpret these results? Maybe Carlo first, and maybe some comment from Thierry.
Well, of course, these are not patients going in the classical trials that have made the guidelines. But of course, is two-sided because they are also extremely high-risk surgical patients. They are not the elective patient of the trials, but you have also some points to prefer a less invasive technique, especially in a fairly elderly patient with other comorbidities, such as this lady. In terms of the intra-aortic balloon pump, well, I don't know. I tend to use it very little, but I agree with Thierry. That was our standard, and we were quite happy. Many times saved our life. I tend to go really minimalistic when I can, with just a radial approach, knowing that a balloon pump is very easy to place it within, and in 3 minutes you can have it. It's true that if you have a true crash in terms of not being able to expand at all, or closing one of the two branches, you can go to a difficult situation. But in that case, really, I don't think much else than an impeller can truly save you. And I tend to rely more on quick stenting to solve the problem. Thank you for not having told me that I had to leave one of the two vessels without a stent. I think it was very difficult, even with the best provisional technique. I agree that there are many alternatives. I think the DK crash is the one that gives you more confidence of having the two vessels always open with access, almost always, even if you have to rewire twice the circ. But you know that after you have done your first kissing balloon, will be fairly easy to do the secondary crossing and opening, and you will not close the ostium, and avoids to have multiple layers of metal in the middle of the lumen, such as for other techniques, like, for instance, shotgun. In the old days, I was using for these very complex cases something that you do in 5 minutes, so two stents together, LAD circ, protruding into the left main. I know there are centers that still do it. I think that you take an extra risk, and is less physiologic, and you will have issues to recross. Is a lady that may need some further work along her coronaries in the future. I think this is a much more elegant and effective and safer technique in terms of risk of anticoagulation. Maybe I spoke too long, Eric.
No, it's okay. We got the point. I see that there is a hand raised by Dr. Lucio. You want to make a comment? And maybe you need to Yeah, go ahead.
Hi, Carlos. Excellent case. The question is, we have a trifurcation with an intermediate ramus compromise. I have a similar case just some weeks ago. The question is, in this case, do you think to try to or to do balloon at the end after putting the stents from left main to LAD and circ, and after the DK crash? I don't know if I understand well, but I think you balloon the intermediate ramus and you final do post. The question is, in some cases, perhaps you can do a dissection intermediate ramus, and perhaps you can compromise the ostium of the stents in LAD and circ. Do you think it's good that, or do you prefer to finish with pod kiss pod?
Well, look, first of all, was not a true intermediate, was a very early diagonal, and that was obvious also with the ultrasound run. I'm sorry I didn't show the proximal segment. I agree with you. Maybe doing a trifurcation, real tracing with 3 balloons can be the best way forward, and then you do your final pot, and you eliminate any risk of distorting, especially the stent on the LAD. Having said that, I went for a relatively small 2.5 balloon. There was no occlusive lesion before, was a good 70% lesion at the ostium of sizable, but not extremely large diagonal branch. I just wanted to make it slightly better. At the end was left a 50% lesion with timid stage growth. I think I went to 6 or 8 atmospheres. I don't think with 2.5 balloon in a stent that was expanded to 4.0 at 22 atmospheres does that much. Having said that, I passed the last ultrasound that we saw, and I didn't see any major change in the shape of my stent in the LAD. So I was fairly happy, but of course, in theory, you have the potential of doing tracing. I'll tell you frankly, I didn't do because the case of the week before was quite cumbersome to get 3 balloons. You need 2.40 and 1.25, so they are bulky balloons, especially if you go with some of them you like to have non-compliant in a 7 French. That case was no problem because I had an impeller. Here I was a little bit reluctant.
Still a little bit an issue of ventricular resistance. I fully agree. We think that impeller is a good tool, and I'm not sure, Thierry, if counterpulsation can make a difference, because if you really crash, you need something more. Yesterday, I did an 84-year-old lady with who had a Takotsubo. He was expected to have an ejection fraction of about 15, which I don't believe. She was anuric yesterday, so she had a critical left main LAD. But not calcified. So basically what we did, couldn't have any assistance, he refused. And I think if you keep your ischemic time short and you're lucky, you have no reflow, it just goes by. So we just basically wired, we had the balloon and the stent already on the wire, we attempted the direct stenting, stent on the wire, wired, pushed the stent, stented it and pulled back, nothing happened. So of course, you need some luck. But I think the issue about assistance is still around. I think the ischemic time is okay, then probably can get around. If you have concomitant disease, and in particular if there is valve disease like aortic stenosis, then you're in trouble. I think combining this situation, that would be suicidal. But if it's pure, even critical coronary disease with short ischemic times, you can get or potentially get around without assistance. Of course, if you expect to have no reflow, then of course, then you shouldn't do that. I think, Lambo, how are we about time? You need to guide.
Yeah, maybe, sorry, Sydney, because of time, we have to proceed to Dr. Henry Chui's case. Henry, are you ready?
Oh, yes.
Yeah.
Thank you. Let me share my screen. So can you all see my slide?
Yes.
So you all here. So I try to be quick because of the time's sake. So my patient is a 80 years old patient with cardiogenic shock. So I'm Dr. Henry Chui from Hong Kong. So my patient is a 18 years old gentleman who enjoy good past health. He is a chronic smoker and he denied any illicit drug use. And he was admitted for high fever for 2 days, cough and with yellow sputum. And also complained of some non-exertional chest pain for 1 day. He's running a high fever with temperature 39 degrees Celsius, and blood pressure was on low side 90/40, and pulse rate is around 80. So I did the auscultation and did not hear any murmur or pericardial rub. So this is the EKG, which show a quite significant ST elevation over the anterior leads V1 to V3 and AVR. and there's ST depression over inferior leaks and also the lateral leaks. And you can see there is some evidence of AV dissociation. So at that junctures, I did the, this is a chest x-ray, and I did the rescan, the bedside ultrasound, which show a poor ejection fraction with global hypokinesia. And there is some severe hypokinesia in the all territories, including the, all vascular territory, including the apex. And there's no pericardial effusion. So we checked the, we did the rapid test for the COVID-19 test, but it's still pending, may take 2 to 3 hours to do. And blood result is, you can see basically the renal liver function is normal, and troponin T was elevated, and the CP, creatine kinase is 2000. So he has to run on some low dose inotropic support, and the urine output was lowish. So so we have to go to the cath lab, and we gain access by ultrasound micropuncture techniques, because we think this patient will need some hemodynamical support. And we thought that there will be some disease in the coronary, but basically it's not, and there's no coronary artery disease at all. So we also did the white heart cath, and it showed the elevated LVDP. The cardiac output is 2.48, cardiac index is 1.55. We also calculate the cardiac power output is 0.28, which is less than 0.6. The PAPI, which is reflect the right ventricular function, and is more than 0.9, which indicate the RV function is adequate. So basically, this patient is suffering from cardiogenic shock. So for the sake of the time, probably I won't let you, I will keep this for you to think. So what hemodynamical support will you choose? We can choose either IBP, ECMO, impeller. We can also increase the dose of vasopressors or the inotropic support, or we can use combination of IBP and ECMO, or impeller and ECMO. So it all depends on your availability in your cath labs, and also financial issue is one of the main reasons, for your choice, because in Hong Kong, actually, impeller is recently, the government had able to reimburse the impeller use in cardiogenic shock under age of 65. So we use more and more impeller nowadays. So the other question is for you to think is, will you perform the endomyocardial biopsy? And how will you treat this patient? Supportive treatment, IVIG, IV methylpapillon, and or the antiviral, or combination of above. So this is just to give you some ideas of the level of support of different devices. So IBP usually 0.6 to 1 liter. So there may be some super responder in case there is a calcified aorta. The aorta is very stiff. So there may be IBP may do a very great job in augmenting the diastolic blood pressure, and hence the support the patient. So impeller CP can provide up to 3.5. ECMO is the good tools, and it can replace the cardiopulmonary function, but there's some problem. So we decided at that point of time to insert in impeller. So after the impeller, you can see the arterial line has a fat, non-pulsatile waveform. And we repeat the cardiac, the white heart cath. We check the PAPI, and the cardiac power output increased to 0.61, and the cardiac index is still on low side, is 1.9, normal is 2.2. So I think we are okay to send the patient to CCU. So, but after 2 hours, this patient still have urea, quite dependent on CP impeller, and the arterial waveform is still a fat line, and some noradrenaline infusion. The lactate is elevated, and repeated echo show the ejection fraction fell to 10% only. So we repeat the white heart, the check the blood from the swan gang catheters, and the cardiac power output is 0.56, and the cardiac index now is 1.7, and the PAPI is low at 0.8. So we decided to escalate quickly to VA ECMO. So we insert the VA ECMO and for the left groin, and then after the initiation of the ECMO, there is a impeller suction alarm. So we have to dial down to P1 and give some fluid challenges according to the wedge pressure, and reduce the ECMO flow to 3 liters, so as to keep the impeller to flow at P1. So at that point in time, the impeller is served as a venting of the LV. So there's some regain of toxicity of the flow on the next day. So on day 2, ejection fraction remained 10, but the troponin and CK has been peaked. And we gradually increase the impeller flow and dial down the ECMO flow so as to increase the forward stroke volume from the heart. I mean, this case has very lucky. So this patient shows sign of LV recovery. You can see the pulsatility of the flow increase. So because of some concern with the line, actually by that time the ICU colleague has already removed the white heart cath, the swan gang catheters. So day 10 there is some short run of VT and the ejection fraction continue to improve. And day 12, the ejection fraction improved to 30, but the patient is running on a high fever. So he was started on meropenem lansoprazole. And they think that the impeller is the culprit for the infection, so they remove it first. But actually, after removal of the impeller, the patient still continued to have high fever. So they have to decannulate the VA ammo, and the wound was closed by the surgical team. And fever was down afterwards, and patient was successfully discharged on day 20 with LV ejection fraction back to 40 on discharge. So, this case is not related to PCI, but more of the some management of the mechanical circulatory support device. So for myocarditis, actually, the incident is difficult to ascertain as largely asymptomatic. 30% can progress to DCM and male predominance, and this patient is having pulmonary hepatitis. And there's some there's some other classes such as acute myocarditis, chronic active myocarditis, and chronic persistent myocarditis. The treatment nowadays is still mainly supportive with an inotropic supported mechanical circulatory device, and there's no convincing data regarding the use of steroid, IVIG, NSAID unless this patient is having, autoimmune disease concomitant like SLE with myocarditis, then steroid maybe have a role. And there's no data regarding different type of mechanical circulatory support device. And most patients with pulmonary myocarditis tend to have full spontaneous recovery, and 93% of 11-year survival. So use of mechanical circulatory device is to bridge to recovery, bridge to transplant, or mechanical circulatory device such as LVAC, or to bridge to a decision. So I think we have to support early to prevent the development of the SIRS, which will be a downward spiral, and we have to actually interrupt this downward spiral early. So before any use of inotropes, if you have already on 3 inotropes, the mortality went up to 80%. So type of mechanical circulatory device actually depends on your local availability. Probably IBP as ECMO is commonly used. Impeller has been there, in my hospital for a few years, but funding is only available in the last years. So there's a lot of problem with ECMO. I've encountered all of them. So actually increase the afterload of the heart and slow the myocardial recovery. And lower limb ischemia is common, and retrograde reperfusion is often necessary. And aortic valve closure and causing the LV distension, pulmonary edema, LV clot formation, subsequent stroke on recovery, aortic sinus thrombosis with coronary obstruction, and the patient has no chance of surviving unless there's a heart transplant. So I actually encountered all of them. So when you started the ECMO, the LV volume would increase, the aortic pressure increase, but the LA pressure also increased. There will be pulmonary edema because the blood is drawn from the venous side, so the LV pressure would reduce. And we have to think of venting of the heart, particularly if there's no pulsatility and the aortic valve is closed, and impeller is probably a good option. So there's some retrospective studies. This is published in 2007 by Federico, and retrospectively analyzed 150 patients, 120 receive ECMO only, and 34 with ECPella. So they did a propensity matching analysis, and we show a reduction in hospital survival, increase in survival, also increase the chance of winning. And although this is not significant, the LV ejection fraction is actually higher compared with ECMO alone. So another study by my colleague in United States is retrospective on refractory cardiogenic shock patient in Cleveland, Ohio, and they compare VA ECMO versus ECPella, and there is primary endpoint is they try to match the data, and the primary endpoint is 30-day and 1-year survival. Is Eeckhout is slightly better than the VAMO alone. And for secondary endpoint, there's no major difference, such as bleeding, dialysis, stroke, and TIA. And the inotropic score is the inotropes total dose in the first 3 days, and basically the inotropes is significantly reduced on patient on impeller. So when to escalate is usually depends on the white heart cath finding and the cardiac power output. We have to keep it more than 0.9. And PEPI, if the PEPI is lowish, less than 0.9, there's evidence of RV failure, and you have to consider RV support. So there's data showing that white heart cath would use of white heart cath will increase the survival in AMI or cardiogenic shock. So for the sake of time, probably I will stop here, and I welcome any questions and from you.
Thank you very much. Very impressive.
So I try to stop.
Maybe maybe we can ask Sydney. You wanted to ask a question before, so maybe Sydney Lowe, any comments on the case? That's quite impressive, yeah.
I think it's a very good case, and I think that, of course, it's financially strapped because of the cost of it. And I think it was very good that you escalated quickly to the Eeckhout or added the ECMO. And I think in terms of weaning, would it be better to wean off the ECMO before the impeller? And I think that is a good demonstration of that competitiveness for the two devices, that we need to get increased experience with how to manage the two. You're turning the impeller down initially, and then also then you don't go the other way where you're trying to turn down the ECMO flows when you're trying to decannulate.
Yeah, I think I agree that weaning the ECMO first and then the impeller would be the best option. But actually, they think there's some hematoma in the impeller, so they want to get it off first because there's evidence of sepsis. So it's more logically to wean the ECMO first before the impeller.
I was impressed by the ECG also. That's why also you did the angiogram. That was quite impressive.
Yeah, actually, it's the first
It's
time.
not really common in myocarditis to see this, yeah.
It's quite uncommon. It's the first time I saw this as well.
Yeah.
So actually, it's quite similar to a MI. I mean, probably left main or very proximal ARD. That's why we are worried. So.
Yeah, absolutely. Very impressive.
I see Dr. Christopher and Dr. Andrew have some comments.
Okay, go ahead.
Okay. First of all, I would like to congratulate you on this great case, and I was very impressed by the ECG, which looks like a De Winter sign of like a proximal LRD or left main, but there was no coronary artery disease at all. These pandemic situation gives us so much stress and so much things to worry about on different levels. And coming back to the ECLS, well, we do only have ECMO, so I would go for ECMO in this patient. But the anticoagulation in COVID patient, did you change your regimen there? Because they're still, you see these patients on COVID that have thrombosis and venous or an arterial. Did you change it? Do you do it more aggressively in these patients?
Yes, actually, we have some hesitation in activation of the cath lab for this patient because running a fever and doesn't quite like MI when I saw the patient. So actually, I was quite hesitant, but I did activate the cath lab in the end, but with maybe 2 hours or 3 hour delays after the rapid test and so on. And that actually, this patient is young. I worry about MI, so that's. We still have some hesitation in activation of cath lab during the SARS, COVID era. And for the, the management, I think we did the same without the COVID pandemic. We don't change. Do it more aggressive in some sense.
Dr. Anshu, do you want to make any comment?
Wonderful case. Although the patient has fever to begin with, but this ST elevation with AV dissociation does go with Takotsubo syndrome also, isn't it? Did you do echo which showed apical ballooning or something, you know?
Actually, I did the bedside echo. Basically, is very global hypokinesias, and it's not that kind of echo look like tacosable. It's actually it's a myocarditis case.
Yeah. That would be very uncommon also in a young man to see this.
Yeah, very uncommon. Yes.
So I think the heart block is very common or relatively common in myocarditis. So it's at least 1 to 2%.
Yeah. I think we have some hot discussion on the chart whether we should do biopsy on this case.
Yeah, that's a good point.
I think that there's some diversion on opinion. So what do you think? How about Jack? What do you think? Will you do cardiac biopsy in those cases in general?
So in some of these cases, we actually go ahead and do pulse without prayer. I think the evidence is not strong, but we don't want to miss a window. And cardiac biopsy in selected cases, I think there are some variety of myocarditis that would benefit from pulse without prayer. But if we have made a decision to do that, we don't delay that action to move towards a cardiac biopsy. But I think there are a variance of opinions. I know the evidence there is not very strong. Yeah.
Unless you look for some very rare myocarditis, which was been mentioned in the panel, yeah. But you should have arguments for that, biological arguments and all that. Yeah. Okay, I think that was really a great case. Do we have to move on, Lam? You're the master of
Yes. The next speaker is Dr. Gupta from India. Are you ready?
Yes.
Yes, thank you.
Hello, good afternoon and good evening, everyone from India. So it's my great pleasure to present a CHIP case in a transcontinental conference. So I'm trained by Dr. Jack. So if you don't like the case, I think the questions can be asked directly to Dr. Jack. So it's a 82-year-old male who presented to us in the middle of the COVID pandemic. He was not COVID positive. This is last July. He had usual risk factors of diabetes and hypertension and had been on medical follow-up for some CAD since 20 years. He had class 3 angina for a few months and presented to us with unstable angina for a week with the diffuse ST changes in all his leads. His initial troponin was negative. And he had an ejection fraction of 40% with inferior wall akinesia. But fortunately, his aortic and mitral valve functions were normal. So this was his diagnostic angiogram. So in the myocardial, we see a very tight distal left main disease, heavily calcified coronaries with the diffuse disease in the LAD, the proximal circumflex. And in the cranial, we can appreciate the left main LAD was very heavily calcified up to the mid segment. And the right was occluded, and the right had been like this since many years, and he had been doing well on medical therapy. And whereas the left system disease had clearly progressed from the time of his last angiogram. So the main questions to us was, of course, he was 82-year-old, so he was offered bypass surgery, but the family and the patient was not willing. And I work in a government hospital. Our operation theaters, the CTBS team was also very reluctant to operate at that time because there was limited staff coming to the hospital in the cardiac center. So then if we had to do the PCI, there was a question of support. He had an ejection fraction of 40% and very diffusely calcified triple vessel disease. And then we had to decide about what mode of plaque modification we need considering the heavy calcification and whether we should do any imaging or we should not. So here the family and the doctors, us all decided for a PCI for him, and high risk was explained clearly considering the age being 82, moderate LV dysfunction and triple vessel disease. A 7 French right femoral artery access was taken, and an IEBP was inserted prophylactically from the left femoral artery, considering a long procedure and long time of ischemia as was discussed in the previous cases also. And I decided that we should go ahead with imaging guided root ablation and then decide further plan. So a 1.5 bar was taken. Mind you, the IVUS was not done initially because I thought the IVUS probably won't cross this mid LAD segment because of the heavy calcification. And after root ablating, So we were gently rotablating considering his age, and we do not have Impella, and we cannot afford Impella routinely in our center. But thankfully, the patient tolerated the rotablation quite well, and the 1.5 mm burr could cross this bend in the mid LAD also. And after that, the diagonal, which was a sizable vessel, was protected, and an IVUS was done. So at this time, the IVUS could pass very easily. So these were the various findings at point 1, 2, and 3. So at point 1, we could see some rota effects at 11 o'clock position. At point 2, that is in the proximal LAD, we see almost a 360-degree ring of calcium with a minimum lumen diameter of 2 mm and a wire bias which is not perfectly favorable. And in the distal left main from 10 to 2 o'clock, we see a calcified nodule, but with a favorable wire bias, which we have modified a little with a small but considering the wire bias is towards the calcified nodule. So after these findings, a 2.5 mm NC balloon was taken, but there was absolute non-expansion of the 2.5 NC balloon at 28 atmospheres. So now this was the problem that what do we do? Because we cannot go ahead with stenting. There is a failure of NC balloon. The large burr was not safe because in the mid LAD, the wire bias was not favorable. And if we had to modify it further, we would have required at least a 2 mm burr. And considering a very long segment of ablation, the risk of slow flow was really there. So we were very afraid to step up the burr to a 2 mm burr for a long segment. So what we thought was that IVL is a very safe and good option, safety being the most important advantage in such a scenario. So 3 mm IVL balloon was taken for the mid LAD across the diagonal. And after a few pulses, the 3 mm balloon, which was initially not expanding, it expanded. And finally, the 3 mm balloon expanded in the proximal LAD. And we then took our 3.5 mm balloon for the proximal LAD and the distal left main. The 3 mm balloon had 20 pulses left. And those 20 pulses we thought about using in the ostium of the circumflex. The initial plan of doing the circumflex was, it was a diffuse lesion. So we had planned 2 stents. Of course, Dr. Thiri can comment, but we thought that we'll modify it with a 3 mm balloon and then end the procedure with 2 stents, but with a T or a tap. But what happened was that in the last pulse, the 3 mm balloon ruptured. As you can appreciate in the movie on the left side. So there was a large hematoma on the left main because the 3 mm IVL balloon ruptured. So the patient immediately became hemodynamically unstable, and as you can see, there is an intramural hematoma in the left main extending to the circumflex more than 20 millimeters. So here the plan, original plan was modified, and we went ahead with a mini crush. So the circumflex was stented with a 3 mm drug-eluting stent, and the left main to LAD was stented with a 3.5 mm drug-eluting stent. A pot was done with a 5 mm balloon in the left main, and a kissing balloon was done with the 3.5 and 3 mm balloons. So a final IVUS was done. And this is the final IVUS. I'll show you the final pictures just in a second. So we can appreciate this final IVUS from the mid LAD. And we see the rota effects from 10 to 2 o'clock. And the stents are well expanded, very circular, which is the advantage of using the IVL balloon. And we can see some calcium fractures at 3 o'clock position. And again, this is the mid LAD, which is a very well open stent, which is very circular with 360-degree ring of calcium. And we are coming into the proximal LAD. So here again, we see some calcium fractures. We are approaching the distal left main. We see the circumflex coming from the 7 o'clock position. Just a few seconds, and So we could achieve a very good stent expansion, which is more difficult, and apposition in this heavily calcified vessel, and the left vein was also well expanded. So this was the pre-IVUS in the midality on the left side, and the post in the midality on the right side. And this is the distal left main where there was a calcified nodule. And on the post, we can see a very good stent area of 16 millimeter squares in the distal left main. And this is the stent areas in the various segments. We could get appropriate stent segments. And this is the pre-result in the cranium. And on the right side, we see the post. And this is the pre and this is the post. So I think diffuse calcified lesions are a big challenge, and patient safety is most important part of planning. So imaging is extremely beneficial. Rotablation and IVL can be complementary and not competitive in some of these situations. But still, the upfront use of IVL should be avoided without prior imaging. Thank you.
Thank you very much. That was an excellent case. We basically had exactly the same this week. We start mostly now, as most of you, with Rota, because we have to go ahead, do then imaging. That's exactly what we did this week also in a right. Then went in with the shockwave, and then the balloon burst at 4 atmosphere. So it is a challenge. Maybe we should ask some other panelists in the team for their comments. Maybe Hung Bang from Malaysia. Are you there, Hung Bang?
Yes.
Hi, hello, hello.
Hello, Hung Bang.
Good morning, everyone. It was a great case. Thanks for the share. I actually typed a question in the box there. When we see lesions like this with a lot of calcification, I wonder how many would still attempt. With a balloon angioplasty. With some of these new balloons, like the scoring balloon, some have claimed that you can actually fragment the calcium and spare yourself from, atherectomy. There's one question. The second thing is, of course, the option between good old rotational versus orbital atherectomy. And how do we choose? Which is safer?
That's a good point. Well, orbital atherectomy is coming in now in Europe. It hasn't been available. It was only approved for peripheral, but now it's also coronary. So we will see. I don't know. It depends on your administration. I would like to go ahead with orbital because I think it has some advantages, but I will have to struggle with the administration here. I wonder what my other European colleagues would say. But maybe somebody who's using orbital can address. Dr. Honda, are you using orbital in Japan?
Hi, I'm Satoshi Honda from Japan. Thank you for excellent case. In Japan, shock wave device cannot be available, but orbital atherectomy is the use of orbital atherectomy is increasing. But orbital atherectomy is not good for severe stenotic lesion. So in that case, we use low ablation atherectomy first, and then we sometimes use orbital atherectomy. But in my case, I'm not so familiar with orbital atherectomy, so it's difficult to say which is better. Yeah.
So maybe ask Dr. Volkov from Russia. So is shockwave overkill? Do we think it's? Do we have too many high hopes? I personally think so. We had too many high hopes with shockwave, but I'm curious to hear your opinion. What is the use of shockwave in Russia?
Thank you, Eric, for question. No, unfortunately, we don't have shockwave in our country. So, like the similar situation in Japan. So, and we use, if we have some very calcified lesion, we use rotablation, and yeah, it's just all of option that we have right now.
It's true.
Eric, I have a short comment about the excellent case of Dr. Gupta.
Yes,
do you agree?
Yeah, of course.
Yeah, I think the discussion that he had was excellent because in this kind of case, you have occlusion of the right, you have a lot of calcification, and the risk is very high. So using a small burr was a very good idea, and then he decided to move to IVL because a small burr was not enough, but using a bigger burr would increase the risk to these patients, risk of the slow flow, especially when you have occlusion of the right. So I think IVL was a very good choice, but I will not have pre-dilate the circ, because the circ was not diseased. There was just an ostial lesion due to the distal lesion of the left main. So you don't need to pre-dilate. You just have to put a stent and open the strut toward the circ. And of course, these balloons are very fragile. So if you try to go to, it was already used. So the risk of a rupture of the balloon can be very high when you reused and you do it in an angulation with a big nodule of calcium. So I think it was a very good choice.
How is the use of shockwave in France, Thierry?
It's increasing very high. So I think for a calcified distal left main, for example, we use it. Of course, it's not reimbursed, so there is a cost issue, but we try to use it as we can. So it's very useful.
But still, I think honestly, we have too much high hopes. We have, I would say, 1 out of 4 shockwaves will burst. Maybe we don't do it very well. We rotablate first, and then still we have bursts at 4 atmosphere. Carlo, you want to make a point? Carlo, can you put on your phone, your microphone? Yeah?
I made already a few written comments, and I mean, of course, it's true, and I think the company somewhat improved the balloon compared with a few months ago when the event was more, or maybe 1.5 years ago, when the event became quite frequent. First of all, in my view, the rupture almost hardly ever happens in the first inflations. And if you leave the balloon in position, nothing happens. The problem is always pulling back along a very calcified segment, or as Thierry said, reinserting into another vessel. We try maybe to divide the ET erogation, 40 for LAD and 40 for the circ. That's not a very good policy, I think. You already have not enough to clear of calcium a lesion most of the times. You should use maybe 2 balloons for 1 lesion rather than half a balloon. The rupture, in my view, is a fairly benign phenomenon. I was very surprised to what I saw in the case of Dr. Gupta. And I'm still convinced that maybe there was also some disruption from the guiding catheter, because the dissection was quite far from the point of rupture. Is a 4 atmosphere rupture. So what happens when this if it's well prepared and there is no air coming down? What truly happens at that pressure? Something may happen if you go to 50 atmospheres with some a bit unusual balloons, but still that's rare, and only if you have a pinhole. And these balloons tend to rupture linearly. And I think, having said that, is extremely annoying, because it's a very expensive device, and if it happens after 2-3 erogations, well, of course, I tended not to be happy at all, and that's something they have to solve. They promise they will improve the balloon quality to the point that they should reach a number of erogation with coronary balloons similar to peripheral balloons, so almost 200. Let's hope that they manage, because I think that will make the device more cost effective. Right now, I tend to agree with your comments, Eric. Sometimes you are somewhat disappointed.
There's a point, you know, the case this week, we rotablated 1.5, 1.25, 1.5, ivested, concentric calcium, large. I think there is large space. It's a perfect case for shockwave. You shock it, and indeed, as you mentioned, it mostly happens later on, at the later stage when you shock it. But then, you know, at I think 4th or 5th inflation, we had a rupture at 4 atmosphere, and that's really surprising. But okay, I think they need to work on the device.
Yeah, but Eric, in fact, it was not occurring during the first phase with the shockwave technology. So I think it's just because they increase the production, and then the global quality probably decreased. So now they are trying to catch up this problem, and in few months I think it's better. So we had a similar problem 6 months before, but today it's the risk of rupture is again very low.
Okay. Alam, Master of Ceremony, how are you with time? Because we have more lectures to go.
Yes. Next, yeah, we should go for the next speaker, Dr. Lochy. Yes, from Belgium.
So let me introduce Stijn. So Stijn is working in Brussels, basically, as you know, half Swiss, half Belgium. And Stijn is working in Brussels, basically my home base, where I did my studies in medicine and my training in cardiology. So I'm very happy to invite Stijn for the next lecture.
Thank you, Eric, for the kind invitation. Dear Chairman, dear colleagues, nice to be here on a Saturday. I will present a slightly different case. Made up this title when faced with not only a coronavirus on the loose, a challenging MitraClip case. I have no conflict of interest regarding this case. So, case is about a 45-year-old male with no relevant clinical history. He has a cardiovascular risk profile with slightly high cholesterol, and he's an active smoker. And in September 2019, he was diagnosed, a new diagnosis of heart failure with reduced ejection fraction, about 30%, 25 to 30%, in a center that was working with us. And the workup showed a spontaneous dissection of the LAD, of the mid-distal LAD, and apparently there was no option for revasc at that moment. And secondary, he had developed a severe functional mitral regurg with an ERO of 40 square millimeters and pulmonary hypertension. So in 2020, beginning of 2020, as you all know, beginning of COVID here in Europe, several episodes, he developed several episodes of decompensated heart failure, and this despite optimal heart failure treatment. He had, I would say, a state-of-the-art heart failure treatment. He had an implantation of an ICD in primary prevention. There was a heart team discussion done in the referring center, and he was declined for a surgical solution for his mitral valve, and he was considered for a MitraClip procedure. But despite continuous worsening of his clinical status, referring to our center, which is the main MitraClip center in the area, had to be postponed because of the COVID pandemic and the burden on the health system. It was quite impossible to do almost any procedure with anesthesiologic support. So it was a difficult time, beginning of 2020. And finally, it was planned for this MitraClip procedure in July of 2020. So this is the image, the first image, the baseline echo, where you can see a severe mitral regurg, hypoakinesia of all the apical segments. You see also here the pulmonary vein flow with the systolic reversal. I hope it plays. Yes, it plays nicely. So here you see the 3D images of the mechanism of this mitral regurg, which is really restrictive and tenting of both leaflets, severe restriction, some annular dilatation. And you can also appreciate that the length of the posterior leaflet is, I would say, enough to accommodate for a XTR, for a MitraClip XTR. So we went for a implantation of a first clip. I think because of the very large, the very broad jet, we had a upfront strategy to go for 2 clips because we also wanted to aim for a good long-term result in this quite young man. So this is the implantation of the first clip, which was, I would say, quite uneventful. And I hope it starts playing, yes. And this is the result after the first clip. I would say it looks quite nice. There is some residual jet medial lateral to the first, mostly lateral to the first clip. We also tried to grade this residual jet, and we thought that it was still, certainly because we were aiming for a very good result and we had an upfront strategy to go for 2 clips, that it was still significant. On the other hand, you already see a improvement, a hemodynamic improvement when you look at the pulmonary vein flow. And this is the implantation of the second clip, again an XTR. I would say implantation was quite smooth, as you mostly see for a second clip. But then we were faced with a I would say difficult problem. The lock line got stuck, and when manipulating this lock line, the clip unexpectedly opened up when trying this to solve this problem. We were able to invert the clip and pull it back in the left atrium. But the clip was at this moment, it became non-functional. We were unable to close the clip, and we were faced with a clip that was not, it was not possible to be recaptured in the guiding catheter, and it was neither possible to withdraw through the septum. So I would say a quite stressful situation at this moment. So we decided to come up with, we came up with this solution. And this was, I would say, quite, maybe a bit on the edge. We released the clip, but it was, of course, still attached to the lock line and the gripper line to create some room for a maneuver. And we placed an additional 14 French sheet in the left vena femoralis, and we crossed the septum parallel to the clip with a terumo straight wire and a multi-purpose catheter in support. Exchanged this wire for an extra stiff wire, as we always do in the left upper pulmonary vein, and we went for a dilatation of the septum with a peripheral balloon, with a 12mm balloon. So here you see us doing this. You see the wire in the 3D image. You see the wire parallel to the clip, and you see us dilating the septum just next to the clip that was stuck on the septum. And then we went over the wire from that left venous access with a transeptal sheet and advanced a gooseneck into the left atrium and snared this clip. Pulled it through the septum, which went quite smoothly, and we pulled it first through the right atrium, and then you see the subcostal images also, and then we pulled it back all the way to the right vena iliaca. So, of course, let's say we had some adrenaline going at that moment, but let's say the case was not finished. So we continued with MitraClip procedure through the left femoral axis, crossed the septum again with the ampullates extra stiff. There was quite a big hole now. And we went for an uneventful and successful implantation of this second, now third MitraClip XTR, just centrolateral to this, I think with a very satisfying result. And then we were still confronted with that clip that was now in the groin. So we removed the CDS from the guide. Through the guide, we introduced again the snare, pulled the whole thing just to the skin level, and called in the vascular surgeon to remove this clip. So I would say, despite all stress, a quite elegant solution. This is the ASD that we still had post-procedure. Of course, we were afraid for a quite large tear, but we accepted this at this moment, and we decided to follow up the patient. The patient follow-up was organized in the referring center. He had a very nice evolution, a very nice clinical evolution. He had a functional improvement to NIA class 1 with no recurrence of acute heart failure events since the MitraClip procedure. And the last echocardiogram, I can unfortunately not give you the images because they were not made over here. He had a ejection fraction that slightly improved to 35%, only a mild mitral regurg, and its pulmonary pressures nicely came down, and there were no signs of right failure, right ventricular overload due to this ASD. So this was I would say the case I wanted to share with you, and I'm open for some questions.
That was very, very nice of you, Stijn. I'm quite impressed by the cold-blooded approach of this case. That's quite impressive. Did you discuss the issue with the company? Because of course the Abbott was the Abbott guy in the room. They must. Of
course, yeah. So the clip, or I would say what was left of it, because it was severely damaged, it was sent to the company. It was analyzed, but they didn't find any malfunction with the clip. I have seen when preparing this case that there are already, especially with XTR, some safety issues when you with the final arm angle, when you open up too much, specifically with the XTR device, with the XTR device coming open and not responding anymore. But it was not in this stage that it happened to us. It was before. It was when handling the lock line. So yeah, we don't really know what happened until now. Okay, I know Abbott is a sponsor here, so I'm. But that we don't have a real explanation of what happened. I know of some safety reports with the final arm angle maneuver, but it was not in this stage, as I said.
It's quite, and I'm also impressed how you left the lock line and the gripper line on the clip. So that must have been quite a challenge, because you were not concerned to have any damage because of that. I'm trying to imagine how you manage that. Having both lines still on the clip. You wanted that for safety reasons, of course.
Yeah, of course, not to have it embolized in the circulation. But when we had still the guide and the CDS attached to it, it was impossible to get something. Then we had to go for a new transceptor. It was not possible to get something across just besides the clip. And we didn't want to go for a surgical solution either. So I think that was the reason we that was the reason we unscrewed it and made ourselves some room to work in that septum.
Jonathan, do you have any comments on this case?
Let's hear for some comments. I should stop talking.
I've seen some cases where on the lock line there's a small knot. So usually before we pull the lock line, we actually kind of feel it, on the part outside. And if there's a knot on one end, we actually pull the knotted end so that the knot doesn't go in but actually comes out. We had one case whereby we accidentally put the knot in, and thankfully, in that case, we really had used strength to just pull the whole lock line out. Luckily, the clip did not open up, and with some force, the lock line managed to be pulled out. But sometimes maybe like a small knot during the manufacturing process on the lock line may be a possible cause.
But embolization of clips are very rare, and less than 5 cases, if I remember well. I have seen a case where it's embolized in the right corner. Yeah, sometimes can see crazy things. Yeah.
Eric, I must say I want to congratulate Stijn. It was a wonderful demonstration of how to bail yourself out. I like the fact that when you had this issue, you left it there and persisted to redeploy a second clip. I mean, get the first clip in first and then bail yourself out and then finish up the case. So I thought that was really a good presence of mind. I wasn't very clear about when you found that the clip malfunction. Is it when you're trying to find an arm angle check, or when you were releasing line? Just before.
So yeah, it was before. It was in the lock line process we had it. We had this problem, but yeah, suddenly at some point this clip came open and it was completely non-functional, and we could only open up but not close anymore. So it was only opening up even more. But this is yeah, that was the luckily, because it was more opening up, we could invert it and got it back, but closing it was not possible anymore.
Mm-hmm. Lam, you need to put on your microphone.
Okay.
Yeah.
Right. I did a lot of these MitraClips, and I've seen a lot, and I was there with the embolized MitraClip in the right. So it is. I would like to congratulate you on the bravery that you finished the job after the clip got loose. I think that there are a couple of things in this case, even before. So one of my trainers told me, or one of my attendings when I was younger, told me that better is sometimes the foe of good. So after the first clip, it looked really good. You got a nice pulmonary vein measurement, and in older patients, maybe more sick patients, I would tend to stay like this and then leave it and see what happens afterwards. But this was a particular case with a pretty young and healthy candidate. So I'm really impressed by your cold-bloodedness to finish the case, and surprised that the hole that you pinched in the intra-arterial septum by the inverted MitraClip is so small. I mean, it was big, but it doesn't really look too aggressive, or that you have to close it afterwards. Do you have any follow-up? Do you look at the TE images? Maybe it's closed up a little bit, or?
Yeah. We are very interested, honestly, to see if this patient develops any significant shunt or something, or right ventricular overload or something. But you do know that this shunting is also like a treatment for patients in heart failure. We have the AFR device, and so we have now some other. So there are some things that can be said but until this moment, the only thing I know that he does not develop any right heart failure at all. The hole is small. I would be interested to do an echo myself, but as I said, this is a patient that was referred to us, and we sent it back to the referring center, and I don't have a new TE. If it is closing up a bit or not, I don't have images on that or really information on that. I don't think he had a real new TE since the procedure was done.
We only close unless there is a right to left shunt, but in this case we expect rather left to right, so we shouldn't be really worried in this patient with heart failure. But
no, but if the hole, if the hole is really big,
yeah, it's big, but yeah, you can follow up. It will not close, definitely not. This one not. But it's surprising how we put all kinds of devices through the atrial septum, and it's quite surprising how this septum is tolerant. You know, that 2 hour aggressiveness sometimes, and then sometimes unexpectedly you have a very big tear in the atrial septum that you have to close. So sometimes quite unpredictable. It all depends on the angle to which you approach the atrial septum and which device you use. So. Lam, you are the master of ceremony.
Yeah. So we proceed to the next case. The next case will be presented by Dr. David Low, consultant cardiology in Yangzhai Hospital. David.
Hey. Okay. So thank you, Lamo. So it is really my great honor to be involved in this meeting. So thank you, the organizing committee and the APSC, for organizing this webinar and giving me a chance to present a case here. So my case is about a patient with cardiogenic shock, and there is some dilemma in antiplatelet therapy. So for the case history, my patient was a 72-year-old lady. She was ADL independent. She had background history of diabetics, hypertension, hyperlipidemia. She also had chronic renal failure with a baseline creatinine of 150. So this time, initially, she present for some non-cardiac problem to the A&E. So she suffered from an accidental fall while playing table tennis with her family members. So she got a right hip injury, but all along there was no syncope and no chest pain. So initially, her BP pulse was stable in the A&E, and you can see the initial diagnosis was a fractured right neck of femur. So by the X-ray. So what happened in the A&E was that while the patient was waiting for transfer to the orthopedic ward, she suffered from a weakness VF arrest in AED. So she regained spontaneous circulation after 7 minutes of CPR. The patient was intubated in AED. And after intubation, she got another PA arrest for 3 minutes. And she regained spontaneous recovery circulation after CPR and was transferred to ICU. So this ECG was the ECG before the cardiac arrest. You can see there was inferior ST elevation, but this ST elevation subsided after the cardiac arrest. So there was a repeat ECG in AED, and in ICU there was no obvious ST changes. So in ICU, the patient required a high-dose inotropic support. She needed noradrenaline 30 ml per hour. She suffered from severe metabolic acidosis, and the lactate level was very high, up to 7.6, and the troponin levels was significantly elevated to 8,000 as well. So I have done an echo for the patient in ICU, which showed very poor airway ejection fraction of 20%, global hypokinesia. The airway was not dilated, and there was preserved wall thickness. So the diagnosis was the patient suffered from a fall with fractured right leg of femur. Together, she suffered from an AMI with post-VF cardiac arrest with severe cardiogenic shock. So I brought the patient to cath lab, and not surprisingly, the coronary looks were really bad. So that was the RCA. You can see that was a diffusely calcified vessel with a critical stenosis at the mid-RCA. And the left side was even worse. So basically, you can see, again, the proximal LAD and the proximal circumflex was very calcified. There was a subtotal occlusion at the mid-LAD after this big diagonal. And for the circumflex, there was 50% stenosis at the proximal part and was calcified. There was some distal diffuse disease. So I think in summary, the patient suffered from triple vessel disease with critical mid-RCA and mid-LAD, calcified lesions, post-cardiac arrest, and cardiogenic shock. So the first question was, should we do PCI in this case? So in my lab, the answers will be yes, because in my center, I do not have on-site cardiothoracic surgical support. So it is impossible for a patient to undergo CABG. So then the second question is, which hemodynamic support device we use? The patient only got blood pressure on high-dose inotropes. So I think if cost is not a concern, then we should use impeller in this case. However, at that time, only IBP was available at that time. So there was no impeller and no ECMO as well. So the last question was, how should we tackle her coronary? So should we do the RCA only, or should we do all? Because for LAD, that was quite risky, because likely we need both patient in this case. So I did a IBP supported PCI for this case, and I attempt the RCA first. So I use a AL guiding and then Y with a NS1 full. So fortunately, the mid-RCA critical stenosis could be dilatable by a usual 2 balloon, and then 2.5 NC, and then a 2.5 angioscope scoring balloon. And then I can did IFAS. The IFAS actually show very diffuse calcified lesion from distal to right to the ostium of the RCA. But in this kind of critically ill patient, I plan for more focal stenting instead of metal jacket from the PLV branch to the osteo-RCA. So I just put one single stent, a 3O times 38 DES from mid out at mid RCA here, and post dilated with 3O NC balloon. So I think the final angiogram result was not perfect, especially there was still have distal diffuse calcified lesions, but I think that was acceptable. And you can see I intentionally need to disengage my guiding because there was pressure damping upon guiding engagement because of moderate disease as the ostia. So the patient tolerate the RCA PCI quite well, so I proceed to LAD as well. So the main dilemma for LAD was whether we need motivation, just like a previous speaker. So I chose a strong supportive guide, a 7-French EBU 3.5 guiding, and I began the procedure by using a turnpike spiral to help my wiring. But I could not cause the mid-LAD tight stenosis by workhorse wire. But I can cause it by filter XT. However, the turnpike spiral could not cause the calcified lesions. So I think at that juncture, we will agree that a rotobation is necessary because when you could not cause anything, it's time for rotobation. So someone would use the microcatheter and then exchange for a rotor wire to try direct wiring by rotor wire. But I could pass a small balloon, a 1.0 and then 1.5 balloon to predilate the calcified lesion to create a small tract. And then I use a turnpike LP to cause the tight stenosis. So that was a turnpike LP. So the turnpike LP could cause the calcified lesion. And then I exchange with a rotor wire 4P. And then that was a 1.5 burr. So the lesion could be prepared by this rotobation. Okay, so that was the scene after rotobation. So luckily the patient could tolerate the procedure quite well. There was no slow flow and no hypotension. And you can see the vessel can be opened up by a 2.5 NC and the scoring balloon. And then I can do a IVUS. But the IVUS actually showed there was still more than 270 degree arc of calcium at mainly at the proximal part of LAD. So I decide to do the rotor shock. So I use a 3O by 12 shockwave balloon to further prepare the proximal to mid LAD. So that was the result after the preparation. So how you stand this patient? So for the stenting strategy, in this critically ill patient, I again plan for more focal stenting. So distally, I plan to land my stent here, but proximally, actually from IVUS, there was no good landing zone. And there was also a significant disease at osteo-LAD. So I need to stent into the left main, but the strategy was a provisional single standing from LAD to left main across the circumflex. So the first stent was a 2.5 by 30 stent at the mid LAD, and then overlap with a 3.5 by 34 BS from LAD into left main across the circumflex provisionally. So that was a result after post-dilatation by 3O, 3.5, and 4 NC balloon. So I think the result was acceptable. So I plan to leave the distal diffuse disease for medical treatment. However, in another view, I find some hastiness at the distal stent edge. So finally, I decide to put one more stent, a 2.5 by 44 stent, more distally and post-dilatation with a 2.5 NC balloon. And that was the final angiogram. So for the progress of the patient, so after PCI at day 2, her LV ejection fraction improved to around 40 to 50%. So IBP could be weaned off, and the patient was extubated and off all inotropes at day 3. She suffered from ventilator-associated pneumonia, but that was recovered, and she could come back to my hand at CCU at day 8. So at that time, she got full neurological recovery. She did not have any chest pain, but the question to me at that time was, so when should patient undergo operation for her fractured hip after PCI? So I have consulted the anesthesiologist. So the tentative only date was day 37 post-PCI because we want to keep the patient for 1 month dual antiplatelet therapy at least after PCI, and then we need to stop the Parfix for 7 days before the operation. So, however, the patient was quite unhappy at that time because she mainly complained of severe right hip pain, and the background status really troubled her. Moreover, she was worried about the long-term mobility because the orthopedic surgeon told the patient that if the delay of the operation was too long, let's say for more than 1 month, then the outcome would be maybe similar to conservative treatment. So I think the main issue is when should we stop the P2Y12 inhibitor before surgery? So for cardiologists, we worry about ischemic events, especially in my patient, we worry about stent thrombosis because this patient had multiple stents and stent into the left main as well. But for the orthopedic surgeon, they need to stop the P2Y12 inhibitor before operation because they worry about bleeding complications. And especially in this case, our anesthesiologists would like to use spinal anesthesia instead of GA because they don't want to put the patient undergo GA after this massive AMI. So for the patient, the consequence of delaying the hip OT is important because the hip OT is not an elective OT. For her, it's a kind of semi-emergent OT. So that should be done as soon as possible. So I had liaised with the surgeon, the anesthesiologist, and the patient for several times. So finally, we agreed to proceed to EOT as soon as possible, possibly within 1 month after PCI. So we need to withhold P2Y12 inhibitor before OT. And I switched the patient from clopidogrel to ticagrelor. So the plan was to withhold ticagrelor for 3 days before operation. And we stopped the ticagrelor around day 21 post-PCI. So we will consider bridging therapy after stopping the oral P2Y12 inhibitor. So what does the guideline say? So according to the guideline, the ESC 2017 guidelines, if both oral antiplatelet agents have to be discontinued perioperatively, a bridging strategy with intravenous antiplatelet agents may be considered, especially if surgery has to be performed within 1 month after stent implantation. So just one slide about the bridging therapy. Because stent thrombosis is an arterial thrombosis, so it is a platelet-mediated process. Therefore, bridging strategy warrant an antiplatelet and not an anticoagulant agent. So those are IV heparin, no mercurate heparin, low use at all. And so we can only use reversible antiplatelet agents. So what are the reversible antiplatelet agents available in the market? So these are the 3 reversible agents. You can either use IV cangrelor or the glycoprotein 2B3 inhibitor like tyrosine or epidifibeptide. So cangrelor is the best agent because it has the shortest plasma half-life, only 3 to 5 minutes, and the offset of action is very fast, only 1 hour. For the glycoprotein 2B3 inhibitor, it is around the offset of action is around 4 to 8 hours. So this is a proposed bridging protocol by the small molecule glycoprotein 2B BA inhibitor like the tyrosine. So in brief, after discontinuation of the P2Y12 inhibitor, usually 5 days before OT, you start the bridging therapy around 3 days before the operation, and then you stop the bridging therapy 4 to 6 hours before the operation. And then after operation, you can resume your oral medication if when appropriate. So for my, okay, sorry. For my patient, I stopped the ticagrelor 3 days before the operation, and then I start the glycoprotein 2B infusion 36 hours before operation, and then stop it around 6 hours before OT. So that was nearly my last slide. So for my patient, we use this protocol, and the patient underwent a right bipolar hip arthroplasty under spinal anesthesia. So the blood loss was 300 ml intra-op. She required 2 unit partial transfusion. Fortunately, the patient made an unremarkable recovery. So on day 1, I can resume the patient on a loading dose of clopidogrel and the maintenance dose. And on post-op day 7, her HB remained static, and she can resume full weight bearing walking exercise post-op, and she could walk with frame with 1 moderate assistance. So that was my conclusion slide. I think this is a case, a complex case with high bleeding risk. And I had an antiplatelet dilemma, which is when should we stop the P2Y12 inhibitor before a semi-urgent OT? So I think that it is a case-by-case decision. So for us, I seldom withhold the Parfix or P2Y12 inhibitor within 1 month after stent implantation. Especially in this case, I really worry about the stent thrombosis because the patient received quite a lot of stents and also stent into the left. And lastly, in special cases, bridging therapy with IV antiplatelet agents may be considered in special cases, like if you need to stop the antiplatelet 1 month after stent implantation, then it can be considered. So that's the end of my presentation. Thank you for your attention.
Thank you very much, David. Every time you present the case, there's something special about it. So really very much appreciated.
Thank you,
many points. I don't think we have all panelists speaking, and if there are some, who wants to start making some comments? There was a question, I'm not sure, maybe you want to answer it, David. I
Yes.
don't know if this is really, somebody of the audience asked if antiplatelet testing may be useful in this patient.
So okay, I think in my lab, I do not have the kit for the antiplatelet test, but I think for this case, I would continue the aspirin perioperatively. So anyway, I need to stop the Parfix or ticagrelor. So the reason why I chose ticagrelor was that because it is a reversible binder, so it can be withheld for a shorter time before the operation. So yeah, to me maybe testing of the platelet, the platelet function may not be very important in this case.
It's not in the guidelines. Yeah.
So what was the opinion of the other panelists?
Okay, Dr. Wong, I don't think we heard you. Maybe you want to make any comments?
Yeah,
Anthony?
Thank you, David, for the excellent case. I think for this case, the fractured neck of femur, although is very common, but from my knowledge, actually, I was told by my orthopedic friends that kind of fractured hips in elderly is actually very lethal. The patient mainly died of complication resulting from bedbound status. So the mortality can be as high as 50% if she was managed conservatively. So this is actually much higher than the chance of stent thrombosis, even we withhold the antiplatelet. So I think it's very fair to push for an early operation, just like this case. But I must say that I don't have any experience in using this kind of bridging intravenous antiplatelet therapy. For me, maybe I will still go for withholding clopidogrel within 1 month and just keep the aspirin. And I will try my best to do the best PCI possible using image guidance, the biggest size possible, and to avoid complications, and then the shortest stance length possible. And then I will discuss with family the risk of benefit of withholding that early termination of that antiplatelet. And of course, after the operation, I will write down reloading of the clopidogrel. I think it is very important as long as the hemostasis could be achieved. Yeah.
Thank you, Anthony. Totally agree with you. But one more, I think, apart from waiting, that we need to reload the antiplatelet. So I think we need to see the patient directly after the operation, because the surgeons sometimes will not help you to resume the antiplatelet. So for this case, actually, I see the patient immediately at day 1, and then give the loading dose of clopidogrel after the operation.
There are a lot of questions here in the I think very nice questions in the conference room, but we don't have, unfortunately, don't have time to share it. Once again, thanks a lot, David. Lam, we need to go on. I guess so. Yeah.
Okay. Then the next speaker will be Dr. Satoshi Sensei. He will share with us some mechanical complications in COVID period.
Thank you. Good afternoon and good evening, ladies and gentlemen, and Mr. Chairman. I'm Satoshi Kitahara from National Cerebral and Cardiovascular Center, Osaka, Japan. I'd like to talk about COVID-19 pandemic is associated with mechanical complications in patients with ST segment elevation myocardial infarction. National Cerebral and Cardiovascular Center is located in Osaka, Japan. Osaka Prefecture is the second epicenter of the COVID-19 pandemic in Japan. Our center is the only national center for advanced and specialized medical care and research in Japan that focuses on cerebral and cardiovascular disease. There are no division of infectious disease or respiratory medicine. Therefore, the number of patients with COVID-19 is very few. As well as other countries, the COVID-19 pandemic is a critical problem in Japan. Number of COVID-19 positive cases are about 430,000 people. The Japanese government declared the state of emergency to control the pandemic. We experienced a STEMI case, which made me feel the effect of COVID-19 pandemic. On 13th April 2020, it was under the state of emergency declaration in Japan. An 87-year-old man with a history of CABG recognized a chest discomfort at 9:30 a.m. He made a call to the health center because he thought the symptom might be due to the COVID-19 infection. However, the health center called back to him at evening and recommended him to visit the Department of Cardiology. Finally, he called EMS and arrived at our hospital at 6 p.m. When he arrived at our hospital, his symptom was remaining. The electrocardiogram showed ST segment elevation. Therefore, he was undergoing emergency PCI under the diagnosis of STEMI. In this case, onset to door time was 8 hours and 30 minutes. A physician asked the patient, "Why did you make a call not to EMS but to the health center when you had the heart attack?" The patient answered, I wondered the symptom was due to the COVID-19 infection. And also, I hesitated to visit the hospital because I feared the COVID-19 infection. I suppose that the COVID-19 pandemic may affect students' mental status and behavior, and it may lead to late presentation of STEMI. As shown in our case, if patients with STEMI stay home, there may be a delay in presentation, leading to worsening symptoms or higher incidence of mechanical complications. Until now, little is known about the impact of the COVID-19 pandemic on mechanical complications resulting from STEMI. Therefore, we hypothesize that patients with STEMI during the COVID-19 pandemic had more delayed arrival and subsequently poorer prognosis than historical cohort of patients with STEMI. We retrospectively analyzed 713 patients with AMI at our center. Of these, 422 patients with STEMI were analyzed. We divided them into two groups, before or after the state of emergency declaration in Japan. In this study, the definition of late presentation was onset to door time was longer than 24 hours. Primary outcome was the prevalence of mechanical complications, which including acute free wall rupture, content rupture, ventricular septal rupture, and papillary muscle rupture. Secondary outcome was onset to door time, treatment management, which including revascularization and circulatory assist device use, and in-hospital outcome, including death and length of hospitalization. Baseline clinical characteristic is shown here. In both groups, mean age was 70 years and 70% were male. The prevalence of hypertension and diabetes mellitus are less frequently in after the declaration group. This is the result. After the declaration, onset to door time was significantly longer, and the proportion of late presentation was higher than before. Rate of primary PCI was lower in after the declaration than before. Incidence of mechanical complications was 14.3% in after the declaration group and 3.6% in before the declaration group. After the declaration group had more severe clip classification. For mechanical complications, surgical treatment was undergone in 10 in 13 cases in before the declaration group and 8 in 9 cases in after the declaration group. In hospital deaths, there were no significant differences in two groups. The length of hospital stay is longer in after the declaration group than before. In uni and multivariate analysis for mechanical complications, after the state of emergency declaration was an independent predictor. In previous reports, the COVID-19 pandemic is associated with reduction in both AMI presentations and primary PCI, and with an increase the rate of late presentation. While the proportion of late presentation of STEMI was increased, I think it was consisted of three factors. In hospital factor, the restriction of admission to the emergency room in PCI-capable hospital may prolong the onset to admission time. Second, in EMS factor, increased number of patients with fever, with or without COVID-19 infection, may disturb quick transport for patients with STEMI. Third, this is what we analyzed in this study. Individuals may not request EMS properly based on the fear of COVID-19. So what can we do in this situation? Individuals need to be educated to call EMS appropriately to prevent delayed hospital presentation. and the global community need to address public concerns and stress the importance of seeking prompt medical attention for symptoms of heart attack. So we announced our result to Japanese media, and our study was published in a Japanese newspaper. This is conclusion. In our analysis, fewer primary PCR procedures, longer onset to door time, and a larger proportion of late presentations among patients with STEMI were observed after the state of emergency declaration in Japan. The incidence of mechanical complications of STEMI increased fourfold after the declaration, even though there are no significant differences with respect to in-hospital mortality. For diseases such as STEMI, in which the time course affects prognosis, EMS activation at the right time is necessary. How is the situation in your country? Thank you for listening.
Thank you, Satoshi Sensei. So I think that is an important and interesting question. How is the situation in your countries? So, Dr. Sergey, how is the situation in Russia? Is it the same, more delayed presentations in STEMI?
I think it's the same situation, not on my country. I think it's the same situation around all of the world, because the people are very afraid of the pandemic, you know, and I think it's a typical situation for whole country, as I said. What do you think?
I think it's a very important thing we saw here. In the first wave, yes. The second wave, the answer is probably no, but we don't have relevant data for Switzerland. But we have the impression. Maybe we can just have around the world. Maybe Thierry, how is the situation in France?
Yeah, exactly the same. So we really have seen a lot of patients not coming because of being afraid to come to the hospital. Also, the mobile care unit were not able to take care of all the patients. So we have seen patients coming 2 weeks or 3 weeks after the MI, and they told us that they called the mobile care unit, the SAMU, and the SAMU said, we cannot come to you. So so it was really, so this was in March last year. Now it's different. Today we have not this kind of situation, but in March and April last year, it was really a very bad situation. And we have seen a lot of patients with mechanical complications that we see in very few cases today. But we have seen that last year.
Yeah. Maybe
how about the situation in Australia?
Australia first. Okay, we'll go to Australia first.
Well, we have low numbers, but I think psychology is the same. So during the early part of pandemic, there was a lot of case numbers dropped, and a lot of older people came later than normal. We had late presenters anyway, normally. But I think that now, despite having only some occasional outbreaks from quarantine, we're still finding that the older people don't want to come. The younger people probably are very much similar to previous to pandemic. Yeah.
We need to hear from Italy, from Germany, and from Argentina. Briefly, who wants to comment?
Maybe I can start, Eric, since unfortunately Italy, as you know, is one of the worst affected countries, and we went through the 100,000 deaths post yesterday. That's really terrible. Having said that, I would say we observed this during the first wave, this delay of presentation, this denial of the diseases as severe as acute myocardial infarction. And Dr. Kitahara was so kind to quote our European Heart Journal paper that the academic centers around Italy published, showing that there was a worsening of prognosis because of that. I confess there was good response in the press to the issue. And during this second wave, despite this being much worse, maybe because there is, more protection for individuals, maybe because they understand that the death toll for not presenting with such a severe disease is worse than any risk that you take with COVID, we basically don't have it. I confess it's good and bad, because right now that our hospitals are already full of COVID patients, we still have almost no change in the rate of at least acute patients coming to be treated, which poses a big challenge, unlike during the first wave. During the first wave, we were a little bit just waiting and doing very little, very concerned, but without being overwhelmed. Now we are truly overwhelmed by loads of patients, both COVID and non-COVID.
Germany, Christoph, and maybe Belgium, Stijn. Are you there?
Yeah. So during the first wave, Germany went through this pandemic situation with regarding COVID pretty well, but the numbers of coronary artery disease and acute myocardial infarction dropped very dramatically, up to 80%, and the patient showed up very late and had mechanical complications, as you guys experienced as well. But we made it the patients pretty hard to go to the hospital. We put up warning signs on the hospital homepage. The GP shut down, and like with the health system was turned down as well. So we made it hard even for the sick patient to come to the hospital, and therefore maybe we didn't see that many cases in the hospital as well. In the second wave, it's different. We see lower numbers on acute myocardial infarctions, but the numbers of COVID increase as well in the hospital. So it's different there. And I think we made some mistakes during the first wave to keep the patients out of the hospitals.
Stijn, you want to comment on Belgium? Then we have to go to
Yes,
yeah.
First wave, we have participated in a Belgian analysis, and but in my hospital we didn't go down that much in the number of MI cases, but in general in the Belgian analysis we see, like everywhere in the world, a pretty important decline in acute MI cases in the first wave. There was a number of press releases regarding non-COVID pathology, that in the general press, that it was important still to come. And in the second wave, I think the cohabitance of non-COVID and COVID was better in the second wave. There was still, the number of COVID patients was very high, but the cohabitance was a bit better, and the patients were maybe also better distributed among hospitals than in the first wave. So we saw that the distribution of patients was a bit better organized in the second wave. That was a bit my impression of first and second wave in 2020. Now at this moment we're still facing, I would say, the decline of the second wave. We're slightly going into the third wave, if I can call it. But the number of acute ACS patients is now quite stable, I would say, like before. Patients have we don't see that much. The very late presentations have become more rare now in 2021 now.
Huang Bang, Malaysia.
Yeah, I think in our first wave we also noticed there was a drop in number of admissions. I think because the travel restriction, especially from the far districts, when they have to travel to the tertiary centers, they are very hesitant. But the recent wave, we don't have the same issue. We're actually starting to see a lot of patients now, and the other thing that we notice is actually the wait list patient. Those patients that were referred early on for bypass surgery, and because of delay and so on, they are now actually coming back with symptoms, and we have to actually now do more PCI for these patients, because the surgical wait list is very long, and it's still a challenge. So we tend to do a more complex lesions these days, and do more multi-vessels in one stage, which we used to do, let's say, in multi-stage.
We are still missing Hong Kong, India, and Singapore. Who wants to comment? And then we need to go on to the last case.
Dr. Anthony, do you want to comment? Because I know Anthony had done some study on this issue.
Well, actually, yes, it's by my colleagues, and we have also the same situation, especially during the first wave in Hong Kong. Well, previously we have done a lot of prime PCIs, but it's very obvious that the time for the patient to present, the first medical contact time, is really delayed, and also with more and more, and when the COVID-19 becomes more and more prevalent, the number of mechanical complications actually increases a lot. And I think even up till now, there are some patients still reluctant to go to the hospitals when they first have symptoms. So even now, I think the number of primary PCI in our center has still be lacking behind when compared to the same time point last year. You know that in winter, there are many more patients coming for STEMI, but not this year. We operators are actually feel more relief. No need to rushing back to hospital as often as in the past years. But of course, for a patient, that may not be a good thing. So I think education to them is really, really very important. And we now also have more stringent protocol to follow, how to handle patients admitted with severe chest pain without the COVID status known. And we also have more rapid tests available now. So I think the situation now becomes much better in handling these kinds of patients.
Okay.
Who wants to
How
comment
about
from India?
India? Dr. Kunta, India, how about Dr. Kunta? Do you want to make some comment?
Actually, the COVID situation in our country also improved a little. I think from November till January, we were having very few numbers in our region. So my region is in northern India, and so in our government hospital, our volumes also came down to almost 20-30% of what they usually were. And now they are back up to about 50-60%. But I think the fear of COVID is, I don't see the fear of COVID in patients now, which was there 6 months back. So more and more patients are coming for procedures. I think now the fear of COVID is more with us, with the doctors, but not with the patients. So patients want to get the procedures done. It is us who are very, very scared of COVID. I think in general population in India, the scare of COVID is not there. It's a COVID holiday for them, but the COVID numbers are still there.
Interesting. Quite a different views. And maybe let's finish with Singapore. If I forgot somebody, please let me know. Jonathan or Jack, who wants to comment?
Yeah, maybe I can give a quick comment. Singapore has been very lucky. We hardly ever did any COVID positive STEMI. Initially, the dropout of case was due to psychology. Now we have so few cases as it's like business as usual. So we don't see this increase in mechanical complication because no one is actually presenting late. So I guess in a sense, we're quite lucky. So I think we'll go to the last case then after this.
Yeah.
Okay. Then the last case will be presented by Dr. Jonathan Yap. Jonathan. Okay, we can see your slides.
Okay.
Yes.
Okay, thank you everyone. Yeah, it gives me great pleasure to end off this session. I promise I won't take too long. I'm standing between everyone and their Saturday. So my case is titled "The Case of Epic Proportions," and you guys will see why in the next few slides. As Dr. Jack said, we are pretty fortunate in Singapore that our cases have been really little. We have had about 60,000 cases, but majority have been in the migrant worker population, of which we only have encountered about 29 deaths. And you see the little graph here, in the last 6 months or so, we have averaged about less than 10 new cases a day, and mainly they are imported. So we haven't really seen very much COVID complications. And so I'm going to just go through a case that I encountered during this COVID era, not directly related to COVID, but somewhat related, as you'll see. So I have a 74-year-old male. He has risk factors of diabetes, hypertension, hyperlipidemia, and asthma. He's got carotid stenosis that he underwent stenting for. For his cardiac history, he had left main and triple vessel disease on his cardiac cath. He declined CABG, and in 2018, he had a multi-vessel and left main PCI. About 2 years later, he came to see me in the outpatient and he was complaining of angina. And so I brought him to the cath lab. We did a cath for him. And on the right, as you can see, these stents are widely patent. And of interest is the lesions on the left. You can see that the LAD is subtotally occluded. It's calcified. It's very tortuous. There are a lot of bands in the LAD, and you can appreciate that on these angiograms. I'll let it run for a while. And then in this caudal views, you can see that the ostial circ, there's a hazy lesion there. And somewhere in the mid circ, there's a borderline in-stent restenosis in the previous stent. So I decided to intervene on the LAD, and my initial plan was to stage the circ in a separate occasion. As you can see, this was a very difficult lesion to wire my workhorse wire. I usually use a Sion Blue, it's some funny branch. So I decided to pre-dilate the proximal segment first to give me more room to actually maneuver the wire. And subsequently, I needed a microcatheter. I used a fine cross and needed a Fuder XTA to finally wire the true LAD distally. You can see that this LAD makes a few acute bends. So that was just the first of many difficulties. And I subsequently proceeded to dilate the entire LAD. So this portion here is the native LAD. It's not stented, and the proximal portion is where the original stents were. And if you can see in this multiple images of when you dilate the proximal stent, you can see a waist. I used scoring balloons, high pressure NC balloons, but this waist just wouldn't break within the stent. So it's a really under-expanded stent from the original PCI. At that point of time in Singapore, we had IVL, but IVL was not available for use without prior permission. So that means the patient has to kind of agree for you to use the IVL and sign a consent before the procedure. And I didn't take such consent, so I wasn't able to use this for this case. So with not much options left, the decision was made to actually rotablate through this under-expanded stent. It's this under-expanded segments midway through the previously deployed stent. So I used the 7 French telescope, to kind of get the rotor burr further down without having to go through the proximal portion of the stent. And as you can see here, proceeded to burr at between 150 to 160 RPM. As you can see here, there's not much give. You can see the rotor burr kind of just going through pretty easily. So, we probably didn't manage to rotablate much of the stent. But after this proximal segment, I rotablated the mid to distal segment, which was also very calcified, and then decided to come back to the proximal under-expanded stent with a bigger burr. So this time to the proximal segment, I used the 1.5 mm burr. I'll just show you, in this motion that I really did it very gently, no rush, no jerking motions, and really, really gentle with the burr motions. And this is the shot after the initial rotablation. I went on to try to further prepare the lesion using angiosculpt. You can see just still a little bit of a waste even after the 1.5 mm burr, but more acceptable. Proceeded to stent the mid to distal with a 2.0 Zions and the proximal segment with a 2.5 Zions. And post-dilated that with a NC30 balloon. And the picture on the right is the picture after the post-dilatation. So I think pretty reasonable results for this case. And by this time, it was already about 3 hours into the case. I was actually pretty tired, and I was planning to actually stop and call it a day and come back to stage the circ. But then he At this moment, he kind of complained of very bad chest pain, even with good flow down the LAD, and the ECG actually showed some dynamic ST depressions. And when I did the caudal shot, you can see in the osteocirc it's so much tighter and so much hazier. I think with all the movement through the left main and the LADs, posterior LAD, it must have caused some plug shift, and I think I had no choice but to actually intervene on this circ right at this moment and not stage it for future date. So I proceeded to DEB the mid-circ ISR, and then put in a stent from the circ to the left main through a reverse culotte technique. There was already a stent in the original left main. And this is a little bit unconventional, but my stent is from the left main to the circ. I was thinking that, if I kept ballooning kissing balloon dilatation of the posterior LAD, this stent has been there for the last 2 years. I'm not sure if I've disrupted any plug. So I decided to actually do it with a DEB. So at least I layer some drug in the osteo LAD O stent, a little bit unconventional, and then a final pot. And so this is the final results for the case. And as I said, bad things usually comes in threes, right? So they're like two things. So 2 weeks later, he actually came back with a cough, shortness of breath, but no chest pain. And he was admitted initially to the isolation ward to rule out COVID because of the cough and breathlessness. He had a bit of wheeze, his history of asthma. So the primary medical team treated him for asthma, and the COVID swab came back negative. One of the very good junior doctors in the team actually was auscultating the patient and noted the pericardial rub, how rare this is, and referred him back to us. So there was no ECG changes. We did a ESR, it was in the hundreds, and echo actually showed the small pericardial effusion. So very likely had some pericarditis. He was already on aspirin and Plavix for his stenting, and I was a bit hesitant to add on an NSAID on top of aspirin. So what I decided to do was to give high-dose aspirin in lieu of NSAID, and add on some colchicine. And I saw him 1 month later in the outpatient. His symptoms had resolved, and the repeat echo showed that the effusion had also resolved. So just 2-3 quick slides. This is the minimum recommended guide catheter diameters for the different burrs for the 1.25, 1.5 mm. There are a lot of numbers here. I don't expect anyone to remember this, but suffice to say that the table below is for the guidezilla. They said that if you want to use a guide extension to do rotablation, a 6 French guidezilla can accommodate a 1.25 mm burr. A 7 French can go up to a 1.5, and the 8 French up to 1.75. For the guide liner, there have been case reports that said the 6 French guide liner can accommodate a 1.25 mm burr. In practice, at least for myself, if I use a guide extension, even for 1.25 mm burr, I think it's probably safer to use at least a 7 French guide extension. You have a lot less difficulty struggling to introduce the burr into the guide extension and withdrawing the burr back out of the body. And if in doubt, you can actually just try it out on the table, before you put the equipment into the patient's body. And lastly, a little bit on rotablation of unexpanded stents. It's off-label, but definitely feasible. There have been numerous case reports. I have one operator in my center who also does it pretty frequently. I had to consult him on this case as well. And the emphasis is really on technique. You need to be gentle, you need to be patient, you shouldn't rush. You don't want to rush and then create a lot of heat, and activation of platelets and lead to no reflow and things like that. Yep, that's it.
That's great. That's surprising, and that's very nice. There are many teaching points in your case. I think this so-called rota stent, I've done it too on a few occasions, and it seems to work because it seems to deep drill the vessel, and then you can, not always, but often complete the job. And I think the idea, of course, of use a drug-eluting balloon for your is understandable, because potentially the barotrauma may cause restenosis, and that I think it's off-label, but I think it's a good idea. It'll be interesting to see how the patient will go. So I think we need we have a few minutes to discuss your case. Who wants to make a comment? I think Hyunbang, you are also using quite some drug-eluting balloons. What is your view? Where are you?
Hi, hello. Yeah, so
Yeah.
I think the in-stent restenosis is always a challenge. Especially when the first procedure was, probably had a lot of calcification to begin with. So, to go back in to try to, to prepare a stented calcified lesion is always hard. So I think it's a great job. I think I don't have much experience with rotablator than, a DCB, but for balloon angioplasty, we go by, I think the German consensus is if we have a minimal recoil of less than 30% and there's no major dissection, the DCB is actually a feasible option for treating in-stent restenosis. It avoid, a second layer of metal, and hopefully, that risk of re-restenosis will be lower. I use drug balloon as well for some of the bifurcations, and I think the consensus also has spelled out similar approach. A very good lesion preparation is a key. With the minimal recoil and bad dissections, DCB can have good results.
Mm-hmm. Yeah. Anybody else wants to make a comment on Jonathan's case?
Yeah, I have a comment.
Okay.
I think when you have in-stent restenosis related to the fact that the stent is mal expanded, which was the case, rotablation can be possible. But of course, we have also OPN NC balloons that are very useful. You can go up to 50 atmosphere, and usually you are able to really open the stent. And IVL is also a very good option. So we have many cases where we are not able to open the stent up to 45 atmosphere with the OPN NC, and then with the shockwave, you are able to open the vessel. So I think the most important is to really have the stent fully open, because even if you use drug-eluting balloon, the risk of re-restenosis is very high if the stent is still not fully open.
Of course, that's very important. Imaging, intravascular imaging can be very helpful. It's off-label to use IVL for in-stent restenosis.
It's true.
People do it.
It's true, but it works.
It works. There was a randomized trial in the early days, randomized trials, rotablation versus balloon angioplasty for in-stent restenosis. You remember that? Very long.
Yeah.
I think Carlo and the older guys.
We have done that many years ago with BMS, and rotablation was working better than balloon.
Yeah. Okay.
So I think, Eric, you're right.
It's not simple to use rotablation in a small stent, 2.25 or 2.5. So it's not simple.
Sydney, I hear your voice in the back.
Yeah, I was saying you're correct. You just mentioned very briefly intracoronary imaging. I think that's one of the mainstays now about understanding what you're dealing with. And but sometimes actually imaging is also not that easy to interpret, because on IVUS all you see is a lot of white and it's all acoustically shadowed. And OCT may be a little bit better, although even then may be quite difficult to interpret. And then you're stuck with doing a lot of these expensive devices, some which are not available in some labs. And I think we've got a lot of success with lithotripsy, but I think it's risky to rota. I haven't got any experience with orbital, but I'm told that you may even grind some stents out with orbital, 6 French compatible, and you can cut a bigger amount of the stent, perhaps. Not that it's indicated for that, but maybe it's. I think some Japanese operators have been able to do that. Maybe that's quite good. And I think that if you understand the mechanism of failure with the imaging, that may be very helpful to get a better result.
I have seen several cases of stent retrieval after, having been implanted long time before, by doing rotablation for in-stent restenosis, because this can happen if you go under the struts, but it can happen, of course. You have to be careful, but as Jonathan mentioned, be careful, and then it should go.
And the stent enhancement is also very simple and useful technology to identify mal-expansion of the stent. We use it every day. I think it's very useful.
Okay, I think it's guys. It's 10:30 in the evening in Singapore and Hong Kong. Time to go to bed. Or I'm not your boss. You have to decide what you want to do. We will enjoy the afternoon here in Europe, and I think our colleagues in Latin America will enjoy the day. That's the funny thing about this kind of webinar. It's just amazing. Yeah. I think Jack, the word is yours. The president has to speak. Huh? Where is Jack?
So, okay, thanks, Eric, for being such a wonderful chair as usual, and Dr. Ho Lam for organizing and putting together this truly transcontinental group. I just like to say I'd like to thank everyone, especially the presenters, the panelists for their comments, and most importantly, the attendees who are watching this live as well as on our social media pages. I think the issues that we presented, although across continents, seems to be the same. I think we're all facing the same crunch at the moment, and it's still great that we can catch up and share this experience so you're not alone. But I do wish everyone a safe journey ahead, and we hope to catch up really soon. So please do keep safe and continue working hard at saving our cardiovascular patients. Thank you very much, everyone, and keep safe. Bye-bye.
Thank you.
Bye-bye. Thank you very much for everyone.
Bye.
Thank you.
Bye-bye.
Bye-bye. Thank you. Bye-bye.
Bye.